Welcome to Civic Buzz, a program of the League of Women Voters Minneapolis. I'm Ellen Van Iwarden, Program Director for the League, and I'll be moderating our presentation tonight. The League is a nonpartisan political organization that encourages informed and active participation at all levels of government, works to increase understanding of major policy issues, and influences public policy through education and advocacy, or as we like to say, educate, advocate, empower, repeat. I'm thrilled to be helping the League with this critical work and encourage you, if you're not already a member, to join us. You can find out more at LWVMpls.org. Tonight, we have two guests I'm very excited to introduce. Excuse me, Dr. Ken Engelhardt, a retired physician who has been working with healthcare for all Minnesota, and our own League member, Ann Jones, who is Vice Chair of Healthcare for All Minnesota and retired nurse. So if people could wait, and after their presentation, we'll have plenty of time for questions. And thank you so much, Dr. Engelhardt and Ann, and take it away.
Will you be starting, Ann?
Oh, well, so Ellen asked if we could kind of repeat a program that I invited her to last November, and it's on, it's really about threats to Medicare. We're very concerned about our public health insurance program for seniors and the disabled. And I was going to show Ken's video, and he said, oh, I could just do it in person. So I want to welcome Ken and thank him for being willing to do this in person so that we can hear him in person and then direct questions if you have some at the end. So you go ahead, Ken.
Thank you, Ann, and thanks, Ellen. I appreciate the opportunity to be here tonight. This is a very interesting topic to me, and I hope you find it to be likewise interesting. I'm going to go ahead and pull up my slides, hopefully here. Okay. And can you see it okay? Okay. Yep. So what I'll be talking about tonight is the history of Medicare and what has been done to it in recent years. And so the title is Medicare, the History, the Destruction by Corporate Profiteers, and what you can and really should do about it. So I'd like to take you back to the time before we had Medicare and Social Security and what it was like to be a senior in those days. In 1913, a lady named Mabel Nassau conducted a study. She was a graduate student at Columbia University in New York. And this study was done before we had pensions in the United States and before we had Social Security. So she looked at people that were living in Greenwich Village, looked at the living conditions of 100 elderly people there. And she found that all of them were poor. 27 of those 100 people were able to support themselves with their life savings. They did lodging, took in lodgers. They did odd jobs, selling newspapers, and some had some life savings, even though they were still poor. Most were too ill or debilitated to work. And back in those days, here in the United States, and for a longer time even before that, in Europe, there were these houses called poorhouses. And really, these places were awful places that were the only option for people who were so poor in their elderly years to live, unless they had a family that could care for them or they were independently wealthy. So the poorhouse population back in those days before Social Security and Medicare, the population consisted of elderly paupers. 2/3 or 66% of the folks in the poorhouse were elderly paupers. The rest of them were out of luck immigrants to the United States, young people with alcoholism, and the mentally ill. the poorhouse conditions were terrible. It was like being in prison, and people who lived in the poorhouse were expected to work, even though they were ill and debilitated. In the poorhouse, the conditions were awful, as I said. There was widespread filth and dilapidation, infestation with rats, mice, and bed bugs. And in 1912, the Illinois State Charities Commission report concluded that these poorhouses were unfit to decently house animals even. So understandably, if you were a person who was elderly back in those days, the thought of going to the poorhouse would provoke great terror in you. It'd be something you definitely wouldn't want to do, but you'd be forced to do because you'd be in poverty and you'd be debilitated. Then what happened, of course, in the 1930s was the Great Depression. And just goes to show you what a mass uprising can accomplish. As a result of the Great Depression, there was a nationwide mass protest following the destruction of lives and the loss of life savings. So in reaction to that, the Social Security Act was passed in 1935. The ability to retire became a mass phenomenon then, and the number of poorhouses, however, did not decrease, because even though people could retire, they were still too poor or too sick, frail, senile, or debilitated to care for themselves. So poorhouses remained. But then in 1946, the Hill-Burton Act was passed, and a massive amount of government funds for hospital construction were passed. 9,000 new hospitals were built after 2 decades. And there's a reason why this happened. In World War II and after, hospital care improved significantly. Prior to World War II, hospitals were basically a place where you went for comfort care and a place where you would go to die. But during World War II, significant improvements in medicine and surgery happened. We had antibiotics created, penicillin and sulfa. We developed mechanical ventilation to keep people alive while they recovered and got off the ventilator. And we had significant improvements in surgery. So therefore, hospitals actually became a place where you could get well when you were treated for your condition and eventually be able to go home. So they no longer were a place where you would go just to die. But what happened then was we still had this population of poor people with no place to go. And so hospitals became the place for the infirm. So in the 1950s, poorhouses did close, but then hospitals filled up with people with nowhere to go. And in response to that, nursing homes were created in an effort to open up hospital beds. Then in 1965, Medicare was passed, but it would only pay for facilities that met basic health and safety standards. And there were issues with facilities being able to meet basic health and safety standards, especially in the South, where there was a significant number of hospitals that didn't meet the basic health and safety standards that a hospital should have. However, there was a fear among the people administering Medicare that there would be a huge backlash from Medicare patients if patients were refused at a local hospital. And therefore, the Bureau of Health Insurance devised a term and a program called substantial compliance. Basically, what it was, if you were close enough to meeting these standards, you could be receiving Medicare funding, and patients could be then admitted to your hospital. So, and be admitted to your nursing home too. So this substantial compliance gave an opening to nursing homes, and there was a massive increase in nursing homes, and that's helped free up hospital beds. 13,000 nursing homes were built by 1970. Now, it's still not an ideal situation for people to have to go to the nursing home in the last years of their life, but it is a place where about half of us will spend at least 1 year of our lives, and it is better than what we had before Medicare, and that was the poorhouse situation. Now, this is a picture. I just think this is a beautiful picture. It shows what the government actually can do to help its citizens. You'll recognize a lot of the faces in this picture. This is the signing of Medicare into law on July 30th, 1965, at the Harry S. Truman Presidential Library in Independence, Missouri. So why is President Truman in this photo? Well, the reason he's in the photo is he was a fierce advocate for a national health insurance fund in 1945. He strongly advocated for it. But unfortunately, despite his best efforts, he was thwarted by special interests like the American Medical Association. But when the bill was passed into law, he was honored to be at this signing for his past efforts to try to get a national health insurance program in place. And as a result of that honor, he and his wife, Bess, who is standing beside him in the yellow dress, were the first recipients of Medicare in the United States. And you'll recognize some other figures in this photo. There's a picture of Minnesota's own Senator and Vice President Hubert Humphrey. There's, of course, Lyndon Johnson signing the Medicare Act into law. And you'll recognize Lady Bird Johnson to the right of President Johnson. Now, there are a lot of people who will say the government can't do anything right, but I will tell you that in 1966, in the days before computers, even in the days before handheld calculators, 19 million Americans were registered for Medicare in 11 months using the good old US Postal Service. So a little bit more about Medicare history. Before Medicare, about 60% of people older than age 65 had health insurance, but older adults paid more than three times more for health insurance than younger people. And even though 60% of people had health insurance, those that were over age 65, you still had a significant number of the population, 40% of elderly, who did not have any health insurance at all. This is what I'm going to say now is a little known fact about Medicare, but it actually promoted desegregation, because in 1966, payments to providers were made conditional on desegregation. And that leveled the playing field. People of color and the traditional old-fashioned white people that got all the privilege were equal in terms of medical care and being able to get medical care. So thousands of waiting rooms, hospital floors, physician practices became racially integrated. And there were improvements in Medicare over time, and there still need to be improvements made. Nothing is perfect on its first go around. And I'm the first to say that there's a lot of improvements that need to be done yet in Medicare, but it is an excellent program that's well respected by seniors in our country. So in 1972, speech, physical therapy, and chiropractic benefits were added to Medicare. Something bad actually happened in the 1970s also, and that was the entrance of managed care into the Medicare program. So the option of making payments to health maintenance organizations to administer Medicare was opened. And it was formalized and expanded as Medicare Part C under President Clinton in 1997 with what was called Medicare Plus Choice. And that name was changed to Medicare Advantage in 2003. So why in the 1970s did we go to part of Medicare being run by HMOs and a managed care type of platform? Well, the thinking was back then, and unfortunately is so embedded that it remains today, that if you have a managed care organization administering Medicare, you can save money and improve quality. And over these 50 years that we've had managed care involved in Medicare, neither one of those things has happened. We have not saved money. In fact, managed care has made it more expensive, and the quality has not improved. And if you think about it, how could you save money really if the goal of these managed care organizations is to maximize profits for their investors? It's difficult to conceive that money could be saved when you're trying to make maximum profits from the program. So that was one of the wrong turns we made in the Medicare program in the 1970s. So in 1982, hospice benefits were added. In 2001, coverage for younger people with ALS or Lou Gehrig's disease was added. And then later, benefits to younger people receiving Social Security disability insurance and those with end-stage renal disease was added. So over time, you can see improvements have been done. And then in 2003, Medicare Part D was added under the presidential administration of George W. Bush. So Medicare initially was administered by the Social Security Administration, and now it's administered by what's called the Centers for Medicare and Medicaid Services, or CMS. In 2018, over 59.9 million people were enrolled in Medicare, and the latest figures I've seen are August of 2022, where almost 65 million people now are enrolled in Medicare. Medicare doesn't cover everything. It covers really about half of the expenses, and the rest is covered by supplemental plans that most people have by joining Medicare Part C or D or Medigap plans. Medicare does have out-of-pocket expenses such as deductibles, co-pays, and also you have to pay for long-term care insurance. Medicare does not cover that, nor does it cover dental, vision, hearing, or annual exams. There are numerous funding sources for Medicare: payroll taxes, beneficiary premiums and surtaxes, co-pays and deductibles, and then general U.S. Treasury revenue. So there are four basic parts to Medicare. The first is Part A, and that's inpatient or hospital care. It covers inpatient admissions. It covers non-custodial care to skilled nursing facilities after the patient has spent at least 3 days in the hospital. And by non-custodial care, I mean temporary care while you get better and able to leave the nursing home. It's not a situation where you're considered more of a permanent resident in the nursing home. Medicare would not pay for that type of situation. And Part A also covers hospice. Part B is outpatient care. So think of your clinic. It does cover some provider services while you're an inpatient. So you may have surgery in the hospital, and that would be covered under Part A, but your surgeon may receive payment under Part B. Part B also covers outpatient hospital charges. So you might get forms of treatment at the hospital, but you're an outpatient there. You're not admitted to the hospital. It also covers provider visits in the hospital setting. I mentioned that earlier. I gave the example of the surgeon. And then also, if your medical care team needs to administer prescription drugs to you, that can be covered under Part B as well. Part C is the part that we're talking about a lot tonight, and that is the managed care portion. It came into really full fruition in 1997 during the Clinton administration. In order to qualify for Part C, or the managed care portion of Medicare, you must be enrolled in Medicare Part A and Part B. An example of the managed care Part C is Medicare Advantage. Under Medicare Advantage, patients are allowed to choose a plan. That's important to remember. Medicare Advantage allows the patient to choose a plan. I'm going to talk about ACO REACH in a few minutes, and that's where patients don't have a choice. They're just put in ACO REACH. But under Medicare Advantage, patients are allowed to choose a plan, and that has at least the same service coverage as you'd receive under Medicare Parts A and B, and often Part D or prescription drug benefits are included with Medicare Advantage. Medicare Advantage has an out-of-pocket expense limit, which Medicare A and B do not have. They don't have out-of-pocket limits. And then finally, Part D, or the prescription drug coverage. As I mentioned earlier, that was passed in 2003 under the Bush administration. And it provides coverage for almost all medications that you give yourself, self-administered prescription drugs. We'll talk a little bit here about Medicare financing. In 2018, Medicare spending was more than $740 billion for our country, which was over 15% of federal spending or federal budget, and was about 3.7% of gross domestic product. A lot of the increased spending that's projected in the future is a result of us baby boomers retiring. Spending is predicted to increase to $1.2 trillion in 2026 in just 3 years. That's an increase to 4.7% of GDP. And enrollment in Medicare by 2030 is expected to be 80 million. As I mentioned last August, we were at 65 million, so it's a steady growth in Medicare patients. And then you can see in 2043 and 2093 what the spending is projected to be: 6% of GDP in 2043 and 6.5% in 2093. And these figures come from the 2019 Medicare Trustees Report. So in response to these federal challenges, there have been cuts to acute care hospitals and skilled nursing facilities. The 2010 Patient Protection and Affordable Care Act, otherwise known as Obamacare, resulted in some cuts to acute care hospitals and skilled nursing facilities, and another act called MACRA in 2015 did the same. So now we'll talk about Medicare Advantage. This is a program where Medicare pays a managed care middleman, which is often a private insurance company, instead of Medicare paying directly to providers. The Kaiser Family Foundation found that in 2021, over 26 million people were enrolled in Medicare Advantage, and that's 42% of the total Medicare population. I'll tell you now that as of this year, about 50% of Medicare patients are enrolled in Medicare Advantage. Taxpayers pay $321 a year more to cover one single Medicare Advantage senior compared to traditional Medicare. So if you multiply the millions of people by $321 a year, that adds up to more than $9 billion per year more to pay for Medicare Advantage than traditional Medicare. The annual gross profit margins for Medicare Advantage plans are over $1,600 a year per enrollee during the years 2016 to 2018. So, talked about Medicare Advantage. This is the next version of Medicare Advantage, and it's called Direct Contracting and Reach. So on this slide, you see a simple and efficient payment system where the US government under traditional Medicare pays directly to your provider. It's just a direct, simple payment, very efficient. On the next slide, you'll see what's called direct contracting or reach. It's an innovation in the Medicare Advantage program where a middleman is inserted in the process. So you see the federal government paying the middleman, who then keeps a portion of the money, and what's not kept is then paid to the provider. So it adds a layer of complexity. And until recently, many people hadn't even heard of direct contracting and reach. In fact, a lot of our elected officials in Washington, D.C. had not heard of direct contracting and reach. But direct contracting was developed by the Center for Medicare and Medicaid Innovation CMMI, which is an obscure agency within Health and Human Services. And CMMI has the power to implement pilot programs and scale them up without congressional approval and often without even congressional knowledge of what's going on. Congress is in the dark oftentimes about these innovations that CMMI is initiating, such as direct contracting and REACH. So here's the next iteration. I showed you traditional Medicare, where the direct payment is made from the government to the provider. I showed you Medicare Advantage, where the middleman is there, who then pays the provider. Now we're talking about ACO REACH and direct contracting. And as you see, there are more people with dollar signs by them, okay? So you see the government paying the middleman who pays your providers. But above that middleman are investors who also are looking to make money from the Medicare program through ACO REACH. And this is money that we as taxpayers pay to the federal government. So not only do you have the middleman there looking to maximize profits, you have the investors above the middleman paying the middleman to enroll patients and maximize profits for them. So you're adding more layers of complexity and more people looking to make money off of the Medicare program, actually extracting money from the Medicare program, money that does not go to paying for patient care. So direct contracting ran until December 31st, 2022, and there were 99 of these direct contracting entities operating at that time. The number has been increasing over time, and virtually any type of company can apply to be a direct contracting REACH middleman, including commercial insurers and private equity investors. Some of these folks have no medical background at all, but they're administering your health program for you. And these applicants are approved to be direct contracting entities without any input from Congress. So a timeline for this, during the Trump administration in 2019 and 2020, CMMI came up with this idea of Medicare direct contracting, and it was launched in April of 2021. People who pay attention to what's going on with healthcare financing in the United States, such as Physicians for National Health Program National, healthcare advocates and labor unions got wind of this direct contracting program. And so in late 2021 and early 2022, a grassroots campaign was started to put an end to direct contracting. So in response to that, in February of 2022, Medicare said, okay, we're going to get rid of direct contracting. And instead, basically all they did was name direct contracting REACH. They just gave it another name, and most of the principles of direct contracting were still there. And as of January 1st of this year, this newly named program was supposed to start. So April 2021, the pilot of DCEs, direct contracting and DCEs, was launched with 53 of them. In January of 2022, we had 99 of these DCEs. And the goal for last year was to enroll 1.8 million new people for that year in Medicare Advantage direct contracting. The ultimate goal, however, is to put an end to Medicare as we know it, put an end to traditional Medicare as we know it, and have the program totally privatized by direct contracting entities by the year 2030. So by 2030, the goal is Medicare, traditional Medicare, will be extinct and the entire program will be privatized. There's been a quiet explosion of Wall Street investors buying primary care practices with potential massive profits being gained over time. But we have fought back. In November and December of 2021, physicians delivered a petition to Secretary Becerra who is the head of Health and Human Services, and also met with Congress people. Many of the Congress people didn't even know about direct contracting. They were in the dark. And you see a picture there of people who went to DC. The petition was signed by over 13,000 people, physicians, other healthcare providers, healthcare advocates, labor unions. In January of 2022, 50+ members of Congress demanded an end to direct contracting. And in February of 2022, Senator Elizabeth Warren held Senate hearings on the bad things of Medicare privatization. And the president of Physicians for a National Health Program, Dr. Susan Rogers, who's in this picture with a white coat and the black derby hat, testified at those hearings. And dozens of articles, op-eds, and letters and calls to Congress and HHS were sent in protest to the privatization of Medicare. Now, one thing to understand about REACH is that it threatens Medicare solvency. On the pie chart to the left, you see traditional Medicare, where 98% of taxpayer dollars go to actually paying for your medical care, and overhead is only 2%. So with Medicare Advantage that came about as a result of Medicare Part C, things changed, where overhead and profit could result in 15% of taxpayer dollars being kept, and 85% of taxpayer dollars would go to actually paying for patient care. But on this latest version of Medicare Advantage, called ACO REACH, the REACH middlemen can keep up to 40% of taxpayer dollars for overhead and profit, and only 60% of taxpayer dollars go to the actual payment of patient care. How do they make money on direct contracting? Well, there's a few ways to do it. One is to increase money coming in from Medicare. So in other words, code your diagnoses high. Second way is to decrease money spent on patient care, which is treating low or withholding treatment. And another is to increase volume through patient enrollment. This chart is a bit busy, but it shows what happens with what's called upcoding. There's a couple terms I need to explain to you. One is called capitation. That is what Medicare patients are predicted to cost the federal government per year based on your medical diagnoses. So in essence, each of us in the Medicare program has what you could say is a price on our heads, okay? So under typical coding, these are the diagnoses your doctor would make, okay? And each diagnosis has some sort of risk score associated with it. So in the patient to the left, under typical coding that your doctor would do, that patient would have a risk score of 1.03, and Medicare would pay the REACH middleman $9,000 a year for that care that's predicted to occur. It's not care that's already been given, it's care that's predicted to occur. So with upcoding, I want to show you what happens with that, and that's where a lot of fraud and abuse is occurring. Okay, so for obesity, in the traditional diagnosis, if the insurance companies go in there and say, no, let's change that to morbid obesity, okay, you see the score going up to 2.73, or 0.273, correction, 0.273. And also, the one that kind of irritates me the most is asthma. That's a diagnosis that we as physicians make, and it's in its own category. It falls under the diagnoses of COPD. So COPD consists of, in adults, asthma, chronic bronchitis, and emphysema. So asthma falls under the category of COPD, but it's a diagnosis unto itself because it's intermittent. It's characterized by intermittent inflammation in the airway and symptoms of cough, shortness of breath, and wheezing. COPD is not intermittent. An emphysema patient has fixed obstruction that does not happen intermittently. So they changed the diagnosis from asthma to COPD, and by doing so, the risk score goes up more. And then taking the congestive heart failure one right way at the bottom, and it says congestive heart failure, diabetes mellitus, and if you add COPD to that also, you kind of double dip there for COPD and you get more risk scores added. So by upcoding, they've changed the risk score from 1.03 to 3.63 for this patient. And as a result, they have increased the payment they receive from Medicare from $9,000 to $32,000 in 1 year for care that's predicted to occur. So upcoding by Medicare Advantage and DCEs, the risk scores of Medicare Advantage patients are 19% higher than traditional Medicare patients. Medicare overpaid Medicare Advantage insurers more than $106 billion from 2010 through 2019, and this upcoding is a mechanism to do that. Capitation, we talked about, that's the annual amount paid for the care you're predicted to receive in 1 year's time under the Medicare program. And they're not, capitation and those risk scores are not care that you actually receive, their care you're predicted that you may need. So they upcode in a variety of ways. These DCEs have sophisticated software to scan for opportunities to do upcoding. They pay doctors to add diagnoses. They send in nurses to your home to talk with you and do some sort of exam in an effort to try to upcode the diagnoses and get paid more. And they actually buy provider practices to control the coding process. I would highly recommend an article to you that appeared in the October 8th, 2022 New York Times under the Upshot. And this was an article that documented the waste, fraud, and abuse that occurred from upcoding in the Medicare Advantage program. It had been going on for years, it'll really illuminate for you the fraud that we've been paying for as taxpayers. As you'll see on the bottom, those two sentences, it says by next year, half of Medicare beneficiaries will have private Medicare Advantage plan. We'll have a private Medicare Advantage plan. That's already occurred, where 50% of people are enrolled in Medicare now, Medicare Advantage. And it also says most large insurers in the program have been accused in court of fraud. In fact, 8 out of the 10 largest insurers in this country in the Medicare Advantage program have been accused of fraud in court. Okay, so the second way these direct contracting entities make money is to minimize the amount they spend on care for you. So if they don't spend care on medical services, they keep that money, and it's a dangerous incentive to ration and restrict seniors' care. This rationing does not happen under traditional Medicare because there aren't people there looking to maximize profits under traditional Medicare. So how do they avoid paying for patient care? Well, the first way is cherry picking. They aggressively market to healthier seniors so that they won't have a lot of medical care necessary, and they try to avoid enrolling the sicker patients. You're probably familiar with pre-authorizations that are necessary for care and denials of care. These are treatments that your care team has recommended for you. These are trained professionals saying that you should have these things done, but the insurance company makes the final decision through pre-authorization and denials. There's also a narrow network of specialists so that if you're out of their network, your care would not be provided. So you may want to see a certain specialist because you know that particular physician is good at what they do. But if they're not in the network of the insurance company, you're out of luck. And the fourth way that they avoid paying is through hidden fees for costlier care. So for example, if you need chemotherapy, all of a sudden you are hit with hidden fees and ones that you didn't expect. And that makes your care costlier and less that the insurance company has to pay for your care. So those barriers I just covered force Medicare enrollees to switch from traditional Medicare when their care is most costly or complex, which is usually the last year of life. So that's the time when most people, a lot of people, a higher number of people anyway, switch from Medicare Advantage to traditional Medicare. They're trying to get things paid for in the last year of their life when their care is the most costly. And then finally, there's a way of increasing profits through enrollment. And with ACO REACH, unlike Medicare Advantage when it first came out, where Medicare Advantage was a choice, patients could choose to enroll in Medicare Advantage. Under ACO REACH, the patient oftentimes doesn't have a choice and doesn't even know they've been enrolled in ACO REACH. It's just been done for them. If they have seen a primary care provider in the past 2 years who's part of an ACO REACH entity, they're automatically enrolled in the ACO REACH program. And as I say, they don't ask for that enrollment. It's just done for them, and oftentimes they don't even know about it. So here's a letter from Fairview Health Services. It could just as well come from Health Partners or Aligner or whatever. But in the second paragraph, you'll see some false statements. It says, your Medicare benefits have not changed. Well, actually, that's not true. Your Medicare benefits have changed if you're under ACO REACH, because if you want to see a doctor who's outside of the network, you're out of luck. And if you don't want to be in an ACO REACH program, you don't have any choice but to leave that ACO REACH program and find another primary care provider who's not in ACO REACH. If you want to stay in traditional Medicare, go to traditional Medicare, you're going to have to leave the ACO REACH program. The second false statement is, it says in the second sentence, your provider asked Fairview Health Services to help see that you get the right care at the right time. I can tell you that, having been in the private sector as an internal medicine physician, that type of thing doesn't really happen. They don't go ask the provider, or poll the providers if they want to join an ACO REACH program. The administration makes the decision, and they tell the providers this is what's going to happen. So that's an example of patients who are now enrolled in ACO REACH. That's a type of form letter that they get. So ACO REACH is a threat to Medicare's future. It threatens Medicare's solvency. I mentioned that 98% of the Medicare budget is actually spent on patient care, where only 60% of patient care can be paid for under ACO REACH. It is a dangerously flawed model, DCE. It radically transforms Medicare and undermines seniors' choices. It incentivizes harmful restrictions on patient care, incentivizes fraudulent diagnostic coding, threatens to bankrupt Medicare, and avoids Congress, and therefore undermines the democratic process. But lawmakers are waking up to this. This is an article that showed up in Common Dreams on February 1st, 2023. And the title of that article was "End the Scam. Democrats Unveil Bill to Change the Name of Medicare Advantage." So there's legislation proposed entitled the Save Medicare Act that would formally change the Medicare Advantage program to the alternative private health plan, in an attempt to make it clear to seniors that the plans are run by private entities such as Anthem, Humana, Cigna, and United Healthcare, and actually aren't run by Medicare. And one of the people introducing that legislation was Ro Khanna, a Democrat representative from California, who declared that it's time to call out Medicare Advantage for what it is: private insurance that profits by denying coverage and I need to move this, and the name is being used to trick seniors into enrolling. He says that's not right. The bill will end the scam by preventing private insurers from profiting off the Medicare brand. Our focus should be on strengthening and expanding real Medicare. So under this bill, what happens is, if an insurance company uses the name Medicare through their Medicare Advantage program, they can be fined $100,000 for each time they use the term Medicare. So what should we do about this program that's privatizing Medicare, ending traditional Medicare by 2030, and costing us a whole lot more in taxpayer dollars? I would urge you to call President Biden. There is the number that you can call. It's limited hours on Tuesdays and Thursdays. You might want to just take out your cell phone, although the PowerPoint slides will be distributed to people attending this meeting. But you still might want to take a picture of this and call President Biden and tell his staffers that you want an end to direct contracting and reach today, which can be done by Biden's executive action. The second thing you can do is call your U.S. representative and your 2 U.S. senators. There's the Capitol switchboard number for you, and also demand from them that they join the fight against direct contracting and reach. If you want to write to your U.S. representative and senators, you can go to USA.gov and look up their contact information. And finally, there's a petition out there, protectmedicare.net. If you go to that site, you can add your name to that petition. It might ask you if you're a healthcare provider, and you can just simply state that you're a healthcare advocate. You don't have to be a healthcare provider to sign that petition. So with that, I have finished my talk, and I'm able to answer questions. It looks like we have 12 minutes before the State of the Union speech, and I thank you for your attention.
Thank you so much. That was so interesting. And we've got 3 screens worth of people. So if we could use the raise hand feature in on your Zoom, that'll help Ann and Ken see who's got questions. And you guys feel free to call on people yourselves. I'll keep an eye out too on the screens. But it looks like we've already got lots of questions.
The first one I see is Margaret Berg.
I'm wondering how our local nonprofit Advantage plans through Alina and UCare and Health Partners, how they measure up in the whole scheme.
The problem happens a lot with the big insurers, like Humana, Cigna, those kinds. It seems, and now I don't have hard facts on this, but in talking to people that have UCare, Medicare Advantage, a smaller program, they like the UCare Medicare Advantage program. And I think these smaller programs aren't prone to the huge waste, fraud, and abuse that happens with these bigger insurers, and that's explained in that New York Times article. So the smaller ones seem to be doing better in terms of taking better care of taxpayer dollars and not upcoding and doing all these bad things, but they're just a small percent of the market. The big players are the ones that have most of the market, and that's why it's so costly. So
I think Alina is Aetna, and they're one of the bad actors.
So the next person I see is Jane. Jane P. There you go.
I won't make you say my last name.
Thank you. That's harder. That's harder than a lot of medical terms.
It's Greek. You should be able to decipher it. Anyway, well, I get lost sometimes in the alphabet here. Does reach, because it's all caps, have a meaning?
It does. It doesn't really help to know what the meaning is. Anne knows what the meaning is, but if you know,
it stands for Accountable Care Organization, which is actually similar. It's a managed care scheme. Accountable Care Organization / realizing equity and access and community health. It's
okay. You're right. It's probably not so meaningful.
Putting lipstick on a pig. And if you go to CMS.gov, you'll see glowing claims about what ACO Reach will do for seniors. Those things, every one of those services is actually done by clinical providers. not by an insurance company. So I really think they're conflating this notion that somehow the insurance company provides telehealth and care coordination. That's simply not true. We are just paying this huge, they're skimming a lot of money and claiming credit for work that needs to be done by your clinicians, your doctors, your nurses, your clinical care team. So I think we need to really dig into those claims and debunk that stuff.
Okay.
Yeah, so it's not so
I-
important to know what the acronym means, really. Just know that ACO REACH is an evolution under Medicare Advantage that's leading to the further degradation of the traditional Medicare program and
Okay.
costing us US taxpayers more money.
Okay, I had one more question, and it has to do with upcoding. Who's actually responsible for the upcoding on
Well,
bills?
ultimately, it ends up being the insurance companies that are doing the upcoding get by with it, and they put pressure on doctors to upcode. We make the initial diagnosis, but the insurance companies have the ability to go in there and change our diagnoses, actually,
Ooh,
to submit to Medicare. So they can upcode for us and tell us, we think you incorrectly made the coding was incorrect, and we think it should be this, and they can change it for you. So that's part of what's happening to Medicare and the private sector these days. Doctors who have gone to 4 years of college, 4 years of med school, and at least 3 years of residency are losing their autonomy and their professional authority and are being overridden by people in insurance companies. So they can change the codes.
wow.
I put the link for that New York Times article in the chat. If you want to go in, it's at the top of your chat. Go in and pull it up, and then you can read it when we're done.
Yeah.
And it shows how some of these big provider groups are also told to game the system.
Okay, thank you, Anne.
The next person I see is Anne.
Yeah, Anne, I'm here. Is there a differentiation between advantage programs and supplemental programs?
Yeah, you mean Medigap programs?
Yes.
Well, I'm not sure anymore because the whole thing is so darn confusing, but I have a supplement program which costs a whole lot more than the Medicare Advantage. And I know people are getting sucked in on the lower costs, so I'm just wanting to know the difference between the two.
So Medicare Advantage, under that program, you need to be enrolled in Medicare A and B, and the same thing applies to Medigap. Medigap is available if you do not want to be in Medicare Advantage, and you can buy a Medigap plan from an insurance person in the state, an authorized insurance person in the state of Minnesota. And it's important to look at the various costs in the Medigap plans. So if you want to keep traditional Medicare, you can do that, and then buy a private Medigap plan from an insurance agent authorized in the state of Minnesota. And it's very good to look at the various Medigap plans and what they cover, because the costs for identical coverage can vary widely. Okay, and you're no longer allowed under Medigap to have prescription drug payment on a Medigap plan anymore. Medicare Advantage does provide prescription drug coverage.
That's
But
crazy.
if you want to stay in traditional Medicare and then have a Medigap plan that covers those gaps that Medicare does not pay for, you should also enroll in Medicare Part D and pay for that, because that will cover your prescription, some of your prescription drug costs. So they're both, Medigap is run by private insurers, but it doesn't have all these problems of upcoding and waste, fraud, and abuse and all this that's going on with Medicare Advantage. And it doesn't have all these investors also looking to make a profit. And it's not, if you notice too, on advertising, well, what's being promoted so heavily by Joe Namath and that type of thing on TV, it's Medicare Advantage, because that's where the money is made.
Right.
The Medigap is not so profitable.
So they're less of a drain on the Medicare system.
Right, they're
Right.
less of a drain on the Medicare system, where Medicare Advantage is threatening the solvency of the Medicare Hospital Trust Fund. And, you know, it can be that Medicare Advantage initially looks cheaper, but once you get into the program and say your care becomes costlier, especially in the last year of life, all of a sudden these hidden fees appear, and that's when the last year of life is when the highest rate of people are asking to leave Medicare Advantage and get back to traditional Medicare. So their costs are actually paid for. And you had your hand up.
Yeah, I think the most important thing to understand about Advantage plans versus Medigap is that it's first of all, it's to your advantage to buy a Medigap or a supplemental plan as soon as you turn 65, because you do not have to go do not have to undergo medical underwriting. You'll automatically qualify. So but it's your policy. It may not be as it may be a little more expensive, but it's actually your policy. If you sign up for an Advantage plan, you have signed your Medicare over to this insurance company. You no longer really have Medicare. You have an Advantage plan. That's why Rokana and others are trying to prohibit them from using the word Medicare, because it is really a bait and switch. And then if it becomes difficult to use and they start making it harder for you to get the care you need, if you need to go back to a Medicare Advantage plan, you may no longer qualify for a supplemental plan. And it could be harder to get, really expensive, or you may not meet their medical underwriting. So it's really a trap. Now the problem is this move to privatize and monetize Medicare is going to trap all of us, which is why we're asking you tonight to take some action to stop the whole privatizing and monetizing Medicare train that has, left the station. So, and put pressure on our members of Congress.
So even though I have the supplement, the Medigap thing, I could just get sucked in the funnel of destruction.
Right.
And
Thank you.
Anne made a good point that when you become eligible for Medicare, you should sign up for regular Medicare, A and B, of course, but it's also important, if you're going to get a Medigap and not go to Medicare Advantage, to get that Medigap plan when you turn 65 and eligible for Medicare. And also it's important to sign up for Medicare Part D at that time as well, because if you delay signing up for that prescription drug coverage under Medicare Part D, and you decide to enroll in Medicare Part D for prescription drug coverage when you're, say, 67 or 68, your premiums will be higher for as long as you're on Medicare Part D. So you do get prescription drug coverage earlier at a cheaper cost if you sign up when you're first eligible for Medicare. So the next person I see is Mary Grina.
Yep. What percentage of the insurers who provide these Medicare Advantage programs are for profit, and how many are not? What percent are not for profit?
I would say the big insurers, like Cigna, Humana, and those are for-profit ones. And so I don't know the exact percentage, but I think the great majority of them are for-profit companies. I don't have the exact number, and I don't know. Ann, do you have it? Ann Jones?
So yes, the big ones that you mentioned. So, well, I think Minnesota is now allowing Blue Cross Blue Shield. Several years ago, the Republicans voted to allow these insurance companies to operate as for-profit entities. I don't know how many switched to selling shares, but it doesn't even really matter, because they can all keep unlimited reserves that we don't really know anything about. So they can call themselves not-for-profit for tax, as a tax status, but they can keep a massive amount of reserves. So not-for-profit's just a tax designation, doesn't mean much anymore.
And I just want to say that Optum runs a big group who goes into different insurance companies, and they look at all the coding and they decide, did they miss diabetes? Then they should add it in, or did they miss that? So that, as you said, it increases the amount of money that the insurer gets.
So they're a big data company, and it's called optimizing coding.
Right.
And by the way, you mentioned United. They are one of the
Oh my
big
God.
companies that are described in the New York Times article. Yeah. So Karen, I see. Oh, Mary, did we answer your
Yep,
question before I move on?
Yep.
Okay.
Yes, thank you very much.
You're welcome. Yeah, Karen.
Yes, I finally unmuted. I'm confused. I am on Medicare, and I am a retiree from the University of Minnesota. So I've had my plan through University of Minnesota Health Benefits for years. And I think it was 2 years ago now, they said, oh, all our plans have to be Advantage plans. That's the only choice you have. So I don't know how they could do that. And I'm still angry about it, but I now have medical advantage.
Well, it's easy to understand why you're, having problems with understanding it. It's exceedingly complex, and it doesn't have to be this way. It shouldn't be this complicated. We should just have traditional Medicare for all, where our bills are paid for, and it's a government for the people that takes care of its citizens by paying for their medical bills. Actually, what's supposed to happen under Medicare Advantage, in contrast to ACO REACH, under Medicare Advantage, you are the one that's supposed to decide whether you want to go into Medicare Advantage or not. Under ACO REACH, the direct contracting entity makes that decision for you, as long as you've seen a primary care provider in their DCE within the past 2 years. They can say, okay, this patient is under our ACO REACH program, and they don't have any choice. If they don't like it, they're going to have to leave our DCE and find another provider outside of our direct contracting entity, our ACO REACH program. So that's the distinction. Medicare Advantage is supposed to be a patient choice, where ACO REACH, patient doesn't have a choice, and oftentimes doesn't even know they've been enrolled in ACO REACH.
Mhm.
So and next I see Janet.
Yeah, I think I was behind some other people, but many of us who are on this are over 65 and have been on something for this for a long time. We had some great information given to us, and so we stayed with Medicare, with the original Medicare, and had Part D. But I have so many of my friends have Advantage, and so what do they do now? They're in their 70s or 80s, and they have Advantage plans. What can they do?
It's difficult. Well, first of all, I apologize if someone has had their hand up for a long time and we inadvertently didn't call on them. But if you've been in Medicare Advantage for a long time, it's tough, because if you want to leave Medicare Advantage and go to traditional Medicare, I think if you've been under Medicare Advantage for a year or more, I think that's the time period, and you want to go back to traditional Medicare, you have to undergo underwriting, and so you may not get approved for traditional Medicare, and there may be higher costs because of the underwriting process. So it's tough if you've been under Medicare Advantage for a period of time. It can be difficult. So yeah, that's all I can say. It's a difficult process. So Diane.
Yes. So we have a supplemental through Blue Cross Blue Shield, but we have our health care provided at Health Partners. And I believe a couple of years ago, maybe 3 years ago, I know it was before COVID, they sent out a letter, and I don't remember the exact verbiage, but it was saying that we are switching to this program. You don't have to do anything, but we're just letting you know that we're switching to a program. And I don't remember exactly, because I just disregarded it. I didn't, but I'm thinking now that maybe they, even though we have a supplemental, and I have a primary care physician there, they stuck us into a bucket. And I don't think that I'm not sure, but I'm suspicious that even if you have a supplemental plan, they are still doing some of those, excuse the word, shenanigans. with upcharging and changing your codings. I'm not so sure about that, because just yesterday they read off some of the things that, some of my health problems. And I said, what is that? I don't have that. And so I think we should all be cognizant and conscious and really questioning our doctors when we see them about things that they've said we have that we know we don't have.
Yeah, and to know whether you're in traditional Medicare or somehow you've been switched over to some sort of Medicare Advantage program.
I do
or-
have a question, but I don't know how to raise my hand on the screen.
Oh.
I apologize.
Okay, so it's good, just to answer that question real quickly, it's good to know if you're under traditional Medicare or if you've been switched to Medicare Advantage, and hopefully you haven't been put into ACO REACH. The idea is to try to stay with traditional Medicare and supplement that with Medicare Part D and
Well, one
Medigap.
more question about that. How do we find out? Will they tell
Yeah.
us?
Exactly.
Yeah, I would say, the business office of your clinic should tell you what insurers they have listed for you, what type of Medicare program you're on.
Okay,
Yeah, I
thank
think
you.
that'd be the place. If you need assistance, getting a Medigap plan, there you can go to Medicare.gov, and there's also a state health insurance office that helps people out with getting Medigap plans and signing up for Medicare Parts A and B and Medicare Part D as well. So Kevin, you had a question?
Well, my situation is I've been on disability for about 20 years, numerous heart surgeries and brain surgeries. And all of this information just blown my mind. I think I'm in a Medigap plan with Cigna. And apparently I'm on a Plan F. And I discovered doing some research that they discontinued the Plan F because they were losing money on it. But I pay for that Medigap, I pay $500 a month. In addition to what I pay for my Medicare. Now, my question is, I've heard all these terms: Medigap, supplemental, direct access, those kind of things. I'm still trying to make head and tails out of those particular terms. How do I find out? I mean, do I have Medigap? Do I have direct access? Do I have,
I think two sources of information, and maybe Ann Jones can supplement this. I think two sources of information for you would be the clinic that you go to, the business office should be able to tell you, what insurance coverage you have. Do you have traditional Medicare with a Medigap plan and Part D for prescription drug coverage?
Yes.
Or are you in a Medicare Advantage program?
I think I'm in a Medicare Advantage, but the prescription is separate. That I can get separate prescription plan. So I'm with Cigna, but I also have I just slipped my mind. I'm sorry, but I have a separate prescription plan. So you can kind of pick and choose. At least that's my experience. You can kind of pick and choose. Once you've got your Medicare, you can kind of pick and choose the Medigap or the supplemental insurance policy and separate prescription plan. Is that right?
Well, if you're under Medicare Advantage, then Medigap is intended to cover what traditional Medicare does not cover.
Correct.
So Medigap is separate from Medicare Advantage. It supplements what traditional Medicare does not cover.
Okay.
Another resource for you to find out and help you navigate all this complexity is each state has what's called a SHIP. It's a state health insurance program or something. It's under Medicare. It's under Medicare.gov, and there are people in the state that you can contact that can help define what you have and guide your choices for you. So each state has that. And the Medicare.gov site can help you out with that too, get you linked up to the people in the state.
All right. It would be great if I could get somebody to consult with me. because I'm paying $500 a month for the Medigap, I guess. And I also pay another $500 a month for prescriptions.
Yeah,
And
my advice would be go to the Medicare.gov site and find that link to our state plan and talk to the people, the counselors under the SHIP program
okay,
for our state. They can help guide you through this very complex process.
thank you so much.
Ken,
This
I
is very
think that
informative. I really appreciate it.
And I think,
I wanted to put in a big disclaimer before we end here. I know the State of the Union is starting and people want to listen, probably want to listen to that. And there's 3 more hands up. We are not, neither Ken or I nor our insurance advisors. We're really out to try to explain our concerns about this trend toward privatizing and monetizing Medicare and our program for seniors and the disabled. So that's our main concern, and give people that information. I guess there's somebody, is there a Jean with a hand up?
Hi. Yes, thank you. I just want to clarify something because I have a sister-in-law who I think is in this situation. You talked about individuals in the last year of life who are on Medicare Advantage plans needing to switch either because they're not having their care plans approved or it's becoming too expensive. But also my understanding is if you leave the Medicare Advantage and go back to Medicare, it's hard to get a Medigap plan at that point because you won't pass the underwriting.
Yeah.
So what happens to those people?
They pay more if they can afford it.
Or they have no option.
Or they go without and they pay out of pocket. That's just why we're trying to warn people.
Right.
A lot of us are past the window of 65. Okay.
and just
I
one
see
other
Kathleen.
thing. Just one thing, Ann, I wanted to mention in chat, Dave Garibaldi, who's also a Healthcare for All Minnesota advocate, put in the link for that SHIP program for our state to help guide you through the process. And Ann is absolutely correct. Ann and I are not insurance agents. We're just expressing our concerns about what's happening to Medicare and how it's being degraded, actually.
Well, thank you for doing that.
Oh, you're welcome. And someone wants the link again in chat to the New York Times article. So Ann, maybe if you can put that in there again, please.
It's at the very top of the chat.
Okay.
You have to go to the top, click on it, and it'll open in your browser. So even if the chat is closed, you should have it.
Okay.
So I'm sorry if we are missing people whose hands have been raised for a while. I'm just seeing what hands I can see. And the next one I see is Kathleen Davis. Yes.
I just wanted to, say that I actually am a Medicare counselor. I've been a volunteer. It's the Senior Linkage Line is the name of the SHIP organization in Minnesota. Excellent counselors who will help you to try to understand the difference between the Medigap and the Advantage plans and all the other issues that are involved. The second thing I want to say is it sounds to me like this issue regarding those DCEs is an administrative issue. So at this point, if you write to Biden and you write to your senators, I mean, the idea is it's not change in legislation, but a change at the administrative level that you want to stop this from going into effect. Is that correct?
That is correct.
Okay, thank you.
None of this went through Congress, and they seem to be either ill-informed or kind of asleep at the switch. They all have been sold the Medicare. They've all been sold the managed care Kool-Aid for 45 years. We have to unravel this notion that somehow managing care by denying and pre-authorizing and all those tactics is somehow saving money. It is not saving money. It is harming people. And CMS has bought in big, and we have to back up. But it's going to be a hard process to get members of Congress to understand this. We'd like to, there's a bill called Protect Medicare bill, meaning you can know, Ro Khanna and Mark Pocan of Wisconsin introduced a bill to prohibit these insurance companies from calling themselves Medicare so that they will stop confusing people. That would be a major change.
So people are still looking for the link to the New York Times article. You know what I'll do, everybody?
It's at the
I
very
will.
top.
I'm gonna add a link to my last PowerPoint slide,
Okay.
and I will just put the link to the New York Times article as the last
Okay, good.
slide in my PowerPoint document. Okay, so the
And
link will.
just so
be
you
in.
know, that's only the latest. There have been several exposés of Medicare fraud. Somehow, you know, it's not breaking through. This one kind of.
And it's not there. This is Dave. It's not there. It's not at the top.
I see it at the
Oftentimes,
top of the chat.
chat disappears on certain screens.
Oh, all right. Okay, I'll put it in again.
Thank you.
And again, I'll add it. I'll add a PowerPoint
Okay.
slide. It'll be the
That'll
final
be good.
slide with the link. So
Okay.
the next person I see, it just says iPhone. I'm sorry, I don't see a name other than it just says iPhone.
I don't know. It's probably me, and I don't know why it doesn't say my name. It should. I'm Glenna Case, and I just wanted to share a story because you can be tricked into Medicare Advantage. That is what happened to me. I had a Medigap. I had Medicare plus a Medigap supplemental plan and a separate drug coverage plan. And I got invited to this meeting in which they explained to me all of the wonderful things and how much simpler my life would be and that it would be cheaper if I went to Medicare Advantage. And they explained to me, so my dog's trying to eat my dinner, that this was no risk because at the end of the year, if I wanted to, I could switch back to traditional Medicare with a Medigap supplemental. And so I thought, well, why not? And I switched into this Blue Cross Blue Shield Medicare Advantage plan, and it was terrible. And so at the end of the year, I tried to switch back to where I had been, but they did not tell me that I was subject to underwriting. And so the plan, yeah, I could have switched back. They also didn't tell me that I could only switch back to the plan I had before, that I couldn't switch to a different Medigap plan. So I was trying to switch back, but I wanted a different one and I couldn't get a different one. And the one that I had before now subjected me to underwriting, and it was so outrageously expensive. There was no way in hell that I could have paid what they were asking to cover me. And so I'm stuck in Medicare Advantage. The good news is in this story, though, is that I left Blue Cross Blue Shield Medicare Advantage and went to UCare Advantage. I'm happier. My doctor's happier. I've gotten excellent care and I have very few complaints. And I don't have to go through all of this prior authorization stuff that everybody else has to go to. But don't let yourself be tricked into being switched to Medicare Advantage.
So I have a question for you. You were subjected to underwriting even though you wanted to get out of Medicare Advantage within a year's time, huh?
Yes.
All right. That's
Thank you
sooner
for
than-
Well, they didn't
validating
say it was
what
underwriting,
was
but
it?
but the price was so high, it was exorbitant, whereas it was perfectly reasonable the first year I had it.
You know,
So
when
I
you
just,
talk, sorry.
so
go
I just
ahead.
assume it was underwriting, because why would it be, 14 times more expensive,
I'm sorry that happened to you, but I'm glad you got in with a better program with UCare.
Yeah.
So Kathleen, I see your hand up.
I just wanted to clarify that 6 month period, you have a 6 month period from the date you turn 65 in which to opt into a Medigap policy. If you are beyond that point, underwriting does exist. After that, you have a 1 year period from that date in which you could switch to Medicare Advantage and then back into Medigap. Otherwise, if you're outside of that period and if you don't have any other what's called special enrollment periods, you will be subject to underwriting. And I think that's something that most people obviously don't have a clue about. And it's really an important point to include in your considerations.
So much. And I know Ellen, you're in charge, so you let us know what you want to.
Yeah, I don't see any more hands raised. This has been fantastic discussion. I really appreciate both of you and the excellent questions we had. Thank you, everyone, for coming. And just a quick plug for next month. Our topic is education, and we have the chair of the Minneapolis School Board, Sharon L. Amin, will be speaking to us, and it will be to fit her schedule on Wednesday night, March 8th, rather than the normal Tuesday night. So just we'll publicize that, of course, broadly, but look forward to seeing you then. Thanks, everyone.
May I make one announcement, Ellen?
Sure.
Our Healthcare for All Minnesota is doing our monthly educational program on Thursday, and it's called Citizen Lobbying. Since this is all about lobbying your elected officials, you know, besides being smart about how you handle your own Medicare situation. But and if you go to the Healthcare for All Minnesota calendar, you can look on Thursday evening and actually register for that program at 6:30 to 8. We have a former Representative Jim Dabney speaking, and then our legislative liaison talking about legislative priorities for Healthcare for All Minnesota. So thanks for letting me make that pitch. Healthcare for All Minnesota, hca.mn.org, and just go to the calendar and you can register.
Yes, and I'll say we'll have the slides of tonight's presentation out on the website where the Civic Buzz is advertised. So look for that in the next few days. Thank you, everyone, and good night.